The hearing will reconvene, and we left off with Ms. Zignani. Thank you for waiting.
Thank you very much. Thank you, Mr. Chairman, members of the committee. It's a pleasure to be here, and having watched the hearing all day, I just want to congratulate you. It's a wonderfully diverse group of people that you've assembled, and you all should be congratulated. It was terrific to watch it.
Thank you.
I think in the interest of time, recognizing you have been here all day, I want to make just a couple of points. First, on behalf of our industry, we believe that the nation needs to pass health reform this year. We don't believe that the passionate debate on which direction or form that should take in any way should deter getting this done. It needs to happen. And to that end, I think it's somewhat disappointing that the focus generally in the press and here in Washington has been almost exclusively on the question of whether to have a government-sponsored plan or not. And I think in many ways one could say that it's obscuring the broad consensus that exists, and indeed that I believe you build on in the legislation in several important areas. First, we see a consensus on improving the safety net and making it stronger. Second, providing a helping hand for working families. Third, a complete overhaul of the market rules. We have proposed an overhaul. You have embedded it in this legislation. We firmly support it, and congratulations for it. We think it's time to move in a new direction, and we are delighted you are doing that. Next, a responsibility to have coverage. We think that's very important because, in fact, the market and many of the questions today about how the market works today really can be answered because until Massachusetts passed legislation requiring everybody to participate, the industry grew up with the rules that are no longer satisfactory to the American people. And the opportunity to get everyone in and participating is an opportunity to chart a new course. Next, the concept of one-stop shopping for individuals and small employers. Next, investments in prevention and chronic care coordination. Next, addressing disparities, bending the cost curve. A number of the witnesses have talked about that today. We believe it's integral to moving forward. And finally, improving the workforce, creating new opportunities, and looking at where we have deficits and attending to them. The committee's draft contains many and actually all of these elements, and we commend you for it. Moreover, we feel that we have to seize the moment as a country and build on this consensus that will accomplish what has eluded the nation for more than 100 years, and that is to pass health care reform. The government-sponsored plan shouldn't be a roadblock to reform. And the key concept of introducing a government-run plan is that it would complete on a level playing field, but that's not what would happen. And Mr. Chairman, as I sat here today, I thought of an analogy. And just to reduce it to a clear and hopefully very direct way to explain our concerns, I want to make an analogy to a race between two people, one that makes the rules and at the same time says to the other competitor, this is my 50-pound backpack and I want you to carry it. Cost shifting from Medicare and Medicaid is that backpack for our health plans, and we can't take it off in this race. The government plan will run without that encumbrance. Moreover, it will add weight to the backpack. We now pay hospitals 132% on average nationally of costs, about 46% above Medicare rates. That has implications for preserving the employer-based system. We believe you cannot, under those circumstances, implications for hospitals and physicians who have long expressed concerns about Medicare rates and the adequacy or not being adequate, and the implications for the deficit, which are not being taken into account. We believe that the most important message we can convey is that we have tools and skills to provide. Indeed, we've pioneered disease management and care coordination. We've pioneered opportunities for individuals to be encouraged when their physician finds it acceptable to substitute generic drugs. We are recognizing high-quality performance in hospitals and physicians, and we're moving down a path of showing results. Embedded in our testimony are some of those results, which are very specific and very measurable about where we are doing and how we are doing a better job. We can help With traditional Medicare, we can bring more of those tools, but we hope that you will recognize the 50-pound backpack and the weight as we explain our concerns with a government-sponsored program. The most important message I can convey to you today is not to let what people disagree on threaten the ability to pass reform this year. Our members have proposed and are committed to a comprehensive overhaul of the current system. We've appreciated the opportunity to discuss key features of the bill with your staff, and we pledge our support to work to achieve legislation that protects consumers and provides health security to patients. Thank you very much.
Thank you. You know, can you turn, your name tag is sort of twisted. Thank you. Thank you, Ms. Trautwein.
Well, thank you very much. And being the last witness of the day, I will try to not repeat everything that everyone else has said. And what I'd like to do is, you know, I agree with everything Ms. Ignani has just said, except that I do want to say one thing, and that is that the details do matter. And one of the things that our members do for a living is we look at a lot of the details. And I feel it incumbent to bring up a couple of those, because I think we do need to make sure that we get these things straightened out before we move forward. And I do want to stress that we don't want to not move forward. We want health reform and we want it done correctly. But I do want to mention a couple of things to illustrate to you that we've got to get some of these things that may appear to be small straight, because they could have huge implications. First of all, I want to mention the rating provisions in the bill. And I want to stress I'm not talking about the no pre-existing conditions. I'm not talking about the no health status rating. I'm not talking about anything like that. I'm talking about specifically the modified community rating provisions. Currently, the bill uses something called an age band of 2 to 1. I'm not going to go into details about that, except to tell you that it's too narrow. And Mr. Chairman, I'd like to use your own state for an example of it being too narrow. New Jersey this year recently went to 3.5 to 1 age bands because what they had was too narrow already and it wasn't affordable for people. The gentleman on the last panel that talked about New Jersey rates of $13,000, they're in a situation of 2 to 1 age bands, and that's one of the reasons why it's too expensive. So we want to make sure that we establish bands that allow wide enough adjustments to make it affordable for more people so that we don't end up losing a lot of the young person participation. In addition, one of our very specific concerns has to do with the fact that this bill tends to lump all groups that are what we call fully insured together, whether they're a group of 10 people, 50 people, or 200 people. And the modified community rating provisions apply to all of them. Today, groups of over 50 on a gradual basis use their own claims experience. And when I talk about claims experience, I don't mean prospective health status rating where they fill out a health statement in advance. I mean that the group develops community rates based on the experience of their own group of employees. It's very cost effective. It allows them to keep their rates lower over time. And I would point out, this is not a market that has problems today. These are not the people that are knocking on your doors telling you that they have a problem. And I would encourage you to not eliminate that ability for them to do that, because the rate shock to the employers, the employees in that category will be fairly significant. I would also like to point out that the grandfathering provisions really need to be improved, and there are a couple of areas that I'm thinking are probably just mistakes. It's a draft inside the bill that ought to be changed. You know, the provision, first of all, is too strict for individuals. It only allows them to add family members, and frequently these policies are reviewed on an annual basis, and other minor adjustments need to be made. For example, a person that has an HSA qualified plan has a legal adjustment to be made relative to the deductible on an annual basis, and the bill doesn't really allow for that. And then groups, of course, are not really grandfathered. They have a phase-in period over 5 years, and we would be hopeful that groups could keep their coverage longer than that period of time. The one thing I want to talk about that I don't think anyone else has mentioned has to do with risk adjustment. This is something that we look at a lot. We're very involved with risk adjustment and reinsurance inside plans to make sure that they're stable. I'm very concerned that the risk adjustment that's suggested is not adequate for starting up this program. The risk adjustment suggested is more something you would do once your exchange had been in effect for a period of time, and it would adjust risk among the plans inside the exchange. It doesn't account for what's going to happen initially when we have lots of people entering the system, many of whom may have serious health conditions. For example, the way that your bill is written today, on day one of guarantee issue, every single person in this country that's in a high-risk pool will come immediately into that pool. So we've got to have something to mitigate the cost of those high risks coming in so that you don't end up with something you don't want, which is a pool that results in costs that are higher instead of lower. And so again, these details are important that we get them straightened out correctly. I would be remiss if I didn't say something else about the public program. Like many of the people that have talked here today, we are very worried about a government-run public program. I want to talk specifically about the cost shifting. There are a lot of things that we have concerned about, but we do definitely see the impact of cost shifting. You know, we've all heard this statistic, but I think it bears repeating again. Almost $1,800 a year for the average family of 4 is a direct result of today's cost shifting without a new public program. And I want to mention one other thing. I see that I'm out of time, but I want to mention this very quickly. We've heard state premium taxes mentioned here many times today, but I want to kind of put a face on that because in New Jersey alone, state premium taxes are $503 million annually to the state, and they are not dedicated to insurance. They fund other programs. We have programs in North Carolina, Connecticut, Kentucky, Pennsylvania, North Dakota that where state premium taxes fund firefighter programs. They buy equipment to fight fires. And so these funds are, I don't think the states can do without this revenue source. And it's another example of how we're not going to have a level playing field, and we need to think this through a little bit more carefully. And I have additional information, but I'm out of time, so I'll go ahead and stop now.
Thank you. And, you know, as I mentioned earlier, I think I did, that whatever your written testimony is, or, you know, data that's attached to it, we'll put it in the record in its entirety.